Introduced Adam Levine, who is a professor of anesthesia, otolaryngology, and structural and chemical biology at the Mount Sinai Hospital and Health System. He is an attending anesthesiologist who focuses mostly in ENT anesthesia, and also is the program director for the Help Center, which is the simulation program in the anesthesia department, and has been the residency program director since 1996. Is that correct, Adam?
Correct. Longest running program director in the country for anesthesiology.
Congratulations.
The
And
condolences.
um, he today is going to talk to us today about some of his work with simulation for safety and improved patient outcomes. And so we're very lucky to have Adam, and thank you so much for agreeing to give us this talk.
Evan, thank you very much, and thanks for inviting me. I was given a bunch of options, whether it was airway management, whether it was sedation, and I'm like, you know what? It's it's time to let's dust off the lecture on simulation and safety. I think many of you, and I've worked with a lot of you, and many of you, if you've been at Sinai for a while, recall what I think was the aspiration, almost the pinnacle of simulation activities when the Ebola scare hit. And many of you will remember that. And we worked side by side with a lot of the intensivists, the nurses, and everyone. And it was the first time that simulation in healthcare sort of amounted to the ideas about simulation in aviation, because there was sort of personal risk involved, and I think there was personal motivation to get trained up, because the people that were getting infected with Ebola were those that were poorly trained, and we saw an outpouring of people. And then we used our skills to institutionalize and standardize the process to make sure that everyone was safe, and we ran interdisciplinary training so that everyone could care for and take care of Ebola patients in the event we got one, which we ended up not getting. This all duplicated and replicated during the COVID scare. And so I think many of you who have personally experienced simulation have recognized personally how powerful the device is and how powerful the technology can be. We'll go over a whole variety of things today, and I don't have your images up because I'm looking at my slides as I'm sharing, but with a show of hands, how many, you could just think for yourself, how many have flown recently, and then think, would you have gotten on that plane if your pilot had not had any recent simulation and you found out about it? And do our patients, and should our patients expect any less from us? And quite honestly, currently they are expecting much less, because many of you in the audience haven't personally had any simulation because it's not a requirement. And so we're going to dive in, explore a variety of different topics. It's a tour de force of activities with simulation. And I will focus on a lot of the things that the group has done here at Sinai in looking at what makes simulation unique, novel, and capable. I have a couple of disclosures. Of course, now it won't start. And I just get honorariums. I have a couple of books, and I'm a member of the editorial board for ASA, and I sit on the resident review committee for the ACGME. It's amazing what you can hear on a Sunday morning, and this is just video for thought. And so this is for Mike Smirkanich, if you don't watch his stuff, but this was interesting and it caught my ear.
Clark, on September 11, you were the guy. You were the counterterrorism czar on September 11. Have you given thought to the way in which a President Donald Trump would have reacted that day?
I have. It's a little disturbing. When something like this happens, you have to have trained, experienced people at the helm. You can't be making decisions on the fly. Those of us who ran the crisis that day had trained to do it. We had had simulations and exercises for years, training for this kind of possibility.
Obviously, the key is they had training, but obviously they couldn't have anticipated or been able to plan. This is not something you plan on the day. And you have to have some form of simulated events, whether it's tabletop simulations, etc., to plan for any crisis that conducts. So even our government aspires to simulation. This also caught my eye. This was a BP ad from a while ago, and I just want you to listen to all the catchphrases that have become part of our dictum in healthcare over time.
Safety doesn't come in a box. It's not a banner that goes on a wall. It's not something you do now and then, or when it's convenient. At BP, it's training and retraining in state-of-the-art simulators, so we're better prepared for any situation. It's giving offshore teams support from onshore experts, so we have extra sets of eyes on our wells. And it's empowering anyone to stop a job if something doesn't seem right, so everyone comes home safely. We're working every day at BP to improve our training, our technology, our culture. Because safety is never being satisfied and always working to be better.
Hopefully you've heard a lot of those catchphrases about the culture of safety, stopping the line or speaking up, training, technology, simulation, and not that and not that BP is the poster child for safety, as we can all remember from, I can't believe this was 14 years ago, the Deep Horizon BP oil explosion and spill in the Gulf, which was catastrophic. And we can all laugh about that, but healthcare isn't the poster child for safety either. And I think it's illegal to give a lecture on safety and/or simulation without actually talking about to err as human. So anytime you hear that, this is the book. It came out in 2000, and basically it attributes us to hurting and/or killing people at a rate of about 50 to 100,000 per year. Some would underestimate it, which we'll talk about that. That's the equivalent of a Boeing 747 falling out of the sky and killing every passenger on it every single day. And we really have not moved this needle very far in the 23 years, nearly a quarter of a century since this manuscript came out. In 2016, Macrae actually estimated that, based on the analysis, that 100,000 was actually a gross underestimate, and attributes medical errors to about the third leading cause of death in America. If you have lemons, make lemonade. So fortunately, at least COVID pushed us down one, and now COVID is the third leading cause of death in America. But medical errors still come in a close fourth. Sinai likes to be a poster child, and I don't know who came up with this one, but clearly every single day we get this, so I don't think we're doing as good a job at Mount Sinai, since our beds are completely full. Maybe we should be promoting Beth Israel, since I think they have a 20% occupancy rate. They might be doing very well. Having said that, anesthesiologists are a poster child for patient safety. Here from the Wall Street Journal, this was again almost 20 years ago. They proclaimed how phenomenal anesthesiologists were in changing our culture, with the Anesthesia Patient Safety Foundation, with the use of simulation, with the ideas of a culture of getting help and forming teams and groups and training to do so, and creating simulation. This was not over the case, and about 10 years before then, we were on the landslide of the heap pile of specialists, really as a dead specialty, according to the Wall Street Journal. So the objections today is looking at teamwork and communication and how we can reduce risk, how simulation can play into that, and is there any evidence for any of this stuff? So we'll go over a quick introduction to simulation and patient safety. We'll talk about the uniqueness of just healthcare education, but how simulation could be an adjunct to that. Talk about the evidence behind such simulation, and whether it ultimately helps to improve patient outcomes. And sort of a tour de force, we'll go into, if there's time, some future directions with the use of simulation and the technology. So quick overview: a simulator is the device, the simulation is the technique that replicates an event. Simulation in general is used when an event is considered too expensive or rare, dangerous, or life-threatening, or unmanageable. And it can be used for both educational training purposes, that includes cognitive, technical, and non-technical skills, those light skills like communication, teamwork, prioritization, follow through, some of the callbacks, some of those things that have resonated with a lot of people now with the timeouts, etc. It can also be used as evaluation, and invariably people think it's their own individual evaluation, but that's sort of very limited. It could be human performance that includes the solo practitioner or solo person, and or how a team works. It can be used to look at the ergonomics of an environment or identify latent safety threats, and also look at how protocols are used and how cognitive aids can be used to help. So what about this patient safety? That just seems to be ubiquitous. This seems to be the aspirational goal of so many in our institution and everywhere. It's the, it's what everyone aspires to have, is ultimate patient safety. But what is patient safety? And if you ask anyone, we'll have some definitions. So the World Health Organization says basically it has to do with don't harm anybody, don't screw up, don't F up, don't mess up. And that includes medications, that includes errors, that includes failures, that includes wrong site surgeries, etc. 50% of which are known to be preventable. From the leapfrog, again, it's don't screw up. Now, this is what we're aspiring to. And imagine if you told your patients, our major goal is not to screw up and hurt you or kill you. One would think that should be the minimum anyone would expect to receive in an institution, and that the aspirational goal should be that they get great care, and that great care is efficiently and economized, but that it's well received and their outcome is superb. But we focus in on not screwing up, and we still can't get it right. Back in 2016, when I first created or embellished this lecture, we weren't doing so good as an institution. We got a C from Leapfrog. We got a little better this year. I just Googled this a little while ago, and we're up to a B. But where we can show improvement, our MRSA infections and bloodborne infections are a little difficult. Infections in the blood. Our surgical site infections are improved. We have improved with surgeries. We have improved with some patient safety, although we're not perfect. We still let people get falls and bed sores. There are still errors, and some of those errors and a high focus of error in how the team works is failures in communication, and here we're not doing so well. And that includes also communications with doctors, communications with nurses, etc. So what is the impact of communication? Well, it's been clearly identified that communication and teamwork failures have led to all of these problems, including poor clinical performance, morbidity, mortality. As you know, there's delays in care and mishaps, etc. In the ICUs, verbal orders and failures in communication. Give 20 of propofol. Well, was that 20 mils or 20 milligrams? Those two things can have very different implication on a patient's outcome, and this all has to do with poor communication and learning from that. Kind of cute. Lapses in communication is thought to be the second leading cause of intraoperative errors, and when we talk about intraoperative, it's any procedural-based errors next to the technical skills. So the technical still wins out, but communication and teamwork problems contribute to those things as well. From the closed claim studies from the ASA and the American College of Surgeons, poor communication has significant preventable errors in our operating rooms, which then obviously in our critical care environments have to also take care of. From the Institute of Medical, the IOM report, 1.5 million people are injured from medical errors and 100,000 die. Of those, of all the sentinel events, 63% of them have communication problems, and it happens in critical environments like yours and mine, the ICUs, the EDs, the ORs. Which is why, and as a timely lecture in what's going on in the institution today, failures in communication teamwork has consistently problems in following policies and have led to problems in sentinel events as well, which is why the Joint Commission has made improving the communication a goal of theirs. So we all work, no one works by themselves. We all work, and especially the intensive care, the operating rooms, the emergency rooms, the codes, the rapid response teams, the difficult airway teams. We all work in multidisciplinary teams, whether it's with surgeons, anesthesiologists, intensivists, nurses, MPs, respiratory therapists, you name it. And we all do our job, and we're all expert in that job. And we all work in different team approaches, and those different team approaches have a taxonomy. The taxonomy is, and one would think you're very fortunate if you have a very fixed taxonomy in that you have a fixed environment. You work in a surgery center, it's the same people, same techs, same nurses, same surgeons, same anesthesiologists, and everyone reads the same languages, and it's almost on-the-job training. You're constantly doing the same thing over and over, and that really is practice on the job. Whereas many of us don't have that fortunate capability, and many of us work in mixed variable environments, like our operating rooms, ICUs, where there's some fixed people, and then so there's some people that come in, whether it's during emergency issues or rotating residents or per diem nurses, etc., or the different surgeons that rotate through the units about the patients, etc. And then we all work in these rapidly forming environments, like I mentioned, like the codes, the rapid response teams tend to be a fixed team. But if it's a code team, you might get people from internal medicine, you might get some people from respiratory therapy, anesthesiologists, etc. And those teams, according to the American Heart Association, the communication is quite poor, the leadership is quite poor. You have many people that can run the team, but if you don't identify who the players are, you have too many cooks interfering with the effectiveness of the patient care. So we have teams of experts, but not necessarily expert teams. Now, we're not alone. And so the FAA and NASA actually recognized, with all of their crashes, analysis, et cetera, that communication was at the hub of many of their catastrophic events, and a managerial component came up with crew resource management, which is basically team training for the FAA, and it is a standardized process. It includes simulator lectures and videos, and in medicine, that crew resource management, or CRM, if you hear the abbreviation, has been morphed into crisis resource management. From the group that initiated, Dave Gaba in Stanford, this was a pictogram of the key components of crew resource management, which has really led to sort of a cultural change in anesthesiology and many fast-paced environments, where if you have trouble, get help. But once you get help, you have a team. Now you got to know what to do with that team, and that means someone has to lead, someone has to delegate, someone has to prioritize, someone has to pay attention. You've all been there, and especially in the ICUs, where there's an airway disaster and all the eyes are looking at the airway and no one's paying attention to the patients having a bradycardic hypoxic event in the background, unless you allocate someone to that role, and that becomes quite relevant and important. As I said, we don't practice as teams. We assume we work as a team. Well, that assumption isn't well, and therefore Team Steps was created. And the whole intro, timeouts, let's introduce ourselves, let's discuss this, let's talk about that, this is all sort of a pre-identified script to pretend that we are a functioning team, to promote the leadership, the communication, the shared mental model of what we're about to undergo. And this has become a national standard in improving patient care by leading to better communication and teamwork. From the ECRI report, the whole variety of things that make up for a safety team. One of those is the learning system, and it really does. The emphasis is that the problem is that we do need to use simulation, much like high-risk industries. And those high-risk industries are actually lower risk because they're known as high-reliability organizations, which have almost a fixation on failure, and they interpret their results and they go back and educate, train, and emphasize the errors, and not to point fingers at people. And these are all the dictum that has used in high reliability organizations, and healthcare would love to aspire to be one of those. And they have adopted many of the philosophical approaches to problems, errors, and catastrophes. Now, obviously, a human designed, even oil rig or nuclear reactor is much even less complex than even the human the nuances of human medicine and healthcare and disease, but the same pitfalls still occur. High reliability organizations do use simulation as a strong component, much like that BP ad that they wanted to get better press and improve their notoriety in the world. These are examples of high reliability organizations. It is memorable when these things go horribly wrong. We remember the Challenger explosion. We remember Chernobyl or 3 Mile Island. When a major plane goes down, it's memorable. If this was advertised every day that we had a medical error, I think it would just fill the press and we would be fatigued by it. Simulation is used in all of these industries. I creep it along. Now, it's used to create teamwork and training, and it's standardized and it's required. Healthcare, it has been adopted in some capacities when there's self-preservation, like Ebola, like COVID. People were motivated to use it, but right now there's no requirement that simulation be used, and we're all short-staffed, and the navigation of adopting the idea that we're going to use simulation and training in lieu of just caring for patients is still not obtainable. Different devices, different technologies, use the right tool for the right job, don't screw in a screw with a hammer, etc. So there are part test trainers, they're the small little pieces of the puzzle, and then there are the full simulators that not just the mannequin, but the monitors, the equipment, the etc. I had the pleasure of overseeing the editorial of a book, and all of these specialties have their own unique simulators and curriculum and use of simulation. Just to pay homage to anesthesiology, I will say that the original mannequin-based simulators came out of departments of anesthesiology. Abramson, back in '69, was actually also responsible, and he was an educator, and he started standardized patients with the urology department. But Abramson actually worked on the original standardized patients as well. So he was involved in the very first simulator and the very first standardized patients. This piece of equipment is believed to cost like $500,000 to over $1 million if built today. It could even fasciculate to succinyl choline. They found that the trainees, the new anesthesiologists, who trained on Sim1 had better intubating skills, and that was very cursory but very sophisticated device. In the middle to end of '80s came two environments that they were practicing simulation. Dave Gaba came out of Stanford, was creating simulation so he could study human performance and sleep deprivation and create a standardized environment, and this device was created. It was subsequently commercialized as an Eagle simulator and marketed in the middle of the '90s. We didn't get that one. Boston was the first one to get that one. Mike Good was the dean, ultimately became the dean of the University of Florida, but now is the vice provost and the head of honcho at Utah, and he's about to step down. But Mike is an anesthesiologist, worked at the VA, and developed a simulator called GAS, Gainesville Anesthesia Simulator, and we were the first ones to have the beta test unit. We received ours, which looked similar to that mannequin on that platform with all of the devices. The thing was very sophisticated, but it could recognize drugs by weighing it in a tiered scale. The pistons came up to the back. It actually was much more reliable than the tethered simulators that we have today, and but it was fixed to that table, and it was pretty remarkable what it could do. But it only ran on DOS. It couldn't be programmed, and if you wanted it to go apneic, you had to bolus a huge dose of opioid or neuromuscular blockade. But we could give negative fentanyl, and it was the equivalent of giving Narcan. That was kind of cool. And we trained up the very first, we received it in '94, sometime the spring of '94, and we split our residents into two groups. For 2 weeks, anesthesia residents only practiced on the simulator. In 2 weeks, they practiced in the standard fashion, and half, and then we tested them. there was no difference. I thought we were creating the super race of anesthesiologists, so I was disappointed. Yet Mike spun it a little better and said, wow, we got over the hump of the standard of the learning curve and never subjecting a patient and not compromising their education skills, etc., which was a better way. I just couldn't get over studying the people back in the simulator because it didn't prove to me that we were actually doing anything novel until that it was possible. Now there's simulators for a variety of specialties, whether it's trauma, whether it's OB, whether it's pediatrics, etc. There are specific part task training devices specifically also for pulmonary and critical care, the bronchoscopes, the airway scopes, the TTE, the TE, etc. You name it, there's a simulator being developed for it. So what about this education and incorporating simulation? Is it really helpful? Well, as we all know, traditional clinical education is compromised by the fact it's an apprenticeship, and it is it's basically time in. Even though we've moved to milestones, we're about to move to competency-based education. Even if you achieve the milestones or achieve competency, you're not going to graduate early. You're just going to more resources are going to be put into it. The problem with clinical education, it is a hit or miss. So you can't guarantee, and I've been running a residency since 1996, and I can't guarantee that every single one of my residents has the exact same education as their cohort, because I can't guarantee that everyone could experience malignant hyperthermia or anaphylaxis or cardiac arrest or a massive PE, etc. Most of them do. We have a busy place, very complex patients, but I can't guarantee it. And it's impossible to practice such rare and complex events. And it's also impossible to sort of throw up your hands and say, you know, it's like, I want everyone to learn how to manage the difficult airway, but it's not like I'm going to take my residents into the OR and say, okay, hey, let's pretend you can't intubate the next one and see what happens. That's never going to happen. Patient care and patient safety is always going to come first. So that kind of, and the ability to interfere with the potential outcomes of what the residents might experience is always going to happen in the clinical environment. Patient safety is always going to come first. We also have some limited outside forces, the ACGME work hours, the DRGs, all of that is limiting the clinical activities of our trainees. So the benefits of being in a simulator, it's an adjunct. It's never meant to replace, it's meant to embellish, and it can fill the void in a lot of things. It can standardize, it can be ramped up, ramped down. You could practice, you can create repetition, etc. And there's easier ways of giving feedback in an environment. It's very hard in the actual clinical environment to give negative feedback. It's not supposed to be meant to be done in public. Well, how else are you giving feedback on someone who is right in front of you performing a laryngoscopy or putting in a line or doing a block poorly, or in the ICUs doing any of those procedures poorly when everyone's around? You can't just say, you know what, let's pause, let's go to a private space so we can give you feedback. The simulated environment becomes the private space, and you can adapt it very easily. Nothing's free, and neither is simulation, and it costs a fortune. And the simulators now could be bought for $10,000, $20,000. That's not the fortune. It's the people running it. It's the space. It's the time away from providing clinical work. No one just has this luxury time to just go in and say, hey, let's spend time doing simulation, even though we believe in our hearts it's probably a good thing. And everyone agrees. We've done multidisciplinary simulation with the ENT department and the nurses, and everyone threw up their hands and said, this is the greatest thing, we should do this quarterly. And I can't tell you it was years ago when we did it, because the resources and the logistics are so challenging. In addition, plastic is still plastic. There's no fidelity or validation of the scripting and the modeling of the scenario. Plastic is still plastic. The things just don't look right. And we're constantly saying, well, the breath sounds don't, for a $250,000 device, you'd think we wouldn't have to say, well, you're hearing the crackles on the right and you don't hear the left. We get the limitations, but this is a reasonable facsimile of real life. When you're evaluating someone's performance in the simulator, you also have to be cognizant that it might not be as real as what you were thinking they would do in the real life, because people become hypervigilant, they're looking for the catastrophic event, or it's a piece of plastic, they don't give a shit, and they become nonchalant about it, etc. So where do we go with the evidence? And it really does matter. Does incorporating the simulator, which and a simulated-based curriculum into one's, all the responsibilities into into the training, etc., and the maintenance of one's training. Does this mean anything? Well, there's some suggestions, and it's all still suggestions. If there's suggestions as improvement, invariably people like it. It appeals to people's adult learning styles where it's goal-directed, experiential, it's exciting. It can be incredibly stressful, but we kind of thrive on some of that stress. And working as a team, you can also reflect upon how you perform against others. There is almost universally high inter-rater reliability. So when two people are evaluating the same performance, it tends to be consistent. And construct validity is high, which means that first year, like anesthesia residents will do better than medical students. Second year anesthesia residents will do better than first years, and medical students thirds will do better, and attendings will do better. So there's some logic to the outcomes, but there still is no definitive proof that this really works. But from the CME literature, neither does this. In fact, you've all been wasting your time because didactic lectures do not do anything to improve outcome. And what has been demonstrated over, sort of a summation of articles is that experiential learning with hands-on and immediate feedback does improve patient care and patient outcome. Well, that sounds like an experiential learning experience with simulation, whether it's part test trainers or full-scale immersive simulation. Over time, the evidence has gotten stronger and stronger, but the early research in simulation was really weak. And it only looked at, yeah, I had fun. Yeah, I liked it. Yeah, I thought it was great. Then it started looking at whether knowledge was improved, whether performance in the simulator was improved, whether performance in real life was improved, and sort of the aspirational goal would be, do people get better, or do we give better outcome? Are people having less errors, less injuries, better outcomes? That's really the aspirational goal of some of the literature, and it's starting to happen. We looked in our group to figure out what precisely are the manipulatable, malleable events that you can change in a simulated environment that makes it a powerful learning environment as an adjunct to the real clinical environment. And to me, it's stress, anxiety, and failure. Always said that. If I asked the group, what was the most memorable case you ever had? 9 times out of 10, it was a horrible, hideous event that led to a catastrophic event and maybe an error at your hands, because it created that emotional charge that drove you to never forget, but also never want to forget, and also review, interview, and investigate the problem. And it's that emotional charge here. The previous generation, it was the Kennedy assassination. Our generation, it was 9/11. If I asked you what you were doing on 9/11, you know exactly what you were doing when you heard that the World Trade Centers were hit with planes. If I asked you what you were doing on 9/12, you'd probably still remember, because the emotional charge was still, the dopamine and catecholamines were still bathing your brain, your limbic system, and you probably still have a fairly good recall. If I asked you what you were doing on 9/10, you wouldn't have any clue. Well, it's the same idea, and here in a simulated environment, you can ramp it up, ramp it down, etc. And that's what we did, and we actually demonstrated with medical students that if you created the environment that created stress, anxiety, etc., they actually did better on the megacode, not on the knowledge, but the megacode. 6 months later, they had better recall. The anxiety that we added was the IV came out. A family member entered and said, "What are you doing to dad?" The nurse kept asking if the patient was dying, and the rest was the other group was just rote. We also looked at whether there is any deterioration if you allow the patient to die, and we discovered, lo and behold, believe it or not, this is a controversy in simulation-based education. Simulators shouldn't die. The student shouldn't be allowed to have such stress. Well, if a student can't handle the stress of a plastic thing dying, maybe they should be thinking of another specialty or profession. And here we demonstrate that, you can die, and guess what? Nothing bad happens. And from the levels of stress, there is a level of stress that's ideal, and then it becomes deleterious in terms of outcomes. And that is kind of cool, because I think the simulator has a plateau effect. There's just so much stress that will happen, knowing that it's still a simulated patient environment scenario. And I think that that's key. We also looked at whether mortality has any impact on the performance of residents. What it really has shown is that the simulations have to have fidelity. We took a group and we broke it up into 3 CA1s. In one group, everyone died. In another group, no one died. And in the third group, they died based on the events that transpired and their experiences. And lo and behold, the performance improved with the simulated variability. When the simulations had a tie to what they were doing and the outcome. The others, you know, they were defeatist if they always died, and they thought they were superhuman if they never died. And so there wasn't a grounding in reality. That was another malleable thing. Ultimately, we replicated what I thought was the ultimate, and we took the most hideous of all scenarios. It's the most memorable of all the scenarios we do with the CA1s in their first start. And it's a line oxygen swap. Invariably, the patients die. But what we did was, with half the group, we had an attending intervene, solve the puzzle, save the day, and the outcome was fine. And there was never a catastrophic event at the residents' hands. And lo and behold, guess what? That became almost unmemorable because it wasn't emotionally tied to the patient dying in their experience. And 6 months later, the performance was deleterious, and the residents that had the bad outcome actually recognized the problem embedded in a different scenario quicker and sooner. And this does replicate the difference between what would happen in a real world and what can happen and use. So independent practice leading to death actually is very powerful and an important use of simulation. Out of the League of Nurses, they actually recognized that as much as 50% of the nursing education could be interjected with simulation and not cause any deleterious effects, which was actually thought to be kind of remarkable in terms of efficiency in education, and with the nursing shortages became an important document that was being published. If I Googled teamwork in simulation, this was probably 2016, there were about 600 articles. Just recently, there are up to 35,000 articles. The exponential rise in the number of simulations and teamwork articles are kind of remarkable. Interestingly, though, the analysis is pretty unremarkable. It's suggestive that teamwork works and that patients have better outcomes and that knowledge about teamwork improves. Basically the articles, even though there's thousands and thousands of articles, they're all very variable. Ultimately, they only could review 29 trials in this review, and that it was sort of, again, a suggestion. Out of this Concord article on teamwork and obstetrics, there's a suggestion that things improve, that the patients would do better, that there was less shoulder distortion, better treatment of hemorrhage. There was suggestions, maybe, sort of, could be's, but because the data, the articles, etc., it's very hard to study, you know, this from a simulated aspect, prospectively, and that the articles weren't very convincing. Again, in this article, they actually looked at hundreds and hundreds of articles to actually see if there was any improvement using simulation in healthcare. They could only come up with 8 articles, and I'm actually going to show you one that we worked on, but only 8 articles actually looked at outcomes specifically, and they came to the conclusion that, yeah, they believe, but it's still preliminary, and we don't have any clear evidence of whether simulation improves outcome. And what's the problem? Well, the N is too low, the complications are somewhat rare, and we don't know if there's opportunity of transference from the simulated environment to patients. Are we learning to treat simulators, or are we learning to treat patients? However, data started to suggest that practicing in a simulator could improve actual real-world improvement in care. This was done with cardiac anesthesia fellows. Half of them, I think it was 10 and 10, learned to come off bypass in a simulator, half didn't, and then they studied them blinded by anesthesiologists, senior anesthesiologists, and the perception was that the group that actually had simulation training to come off bypass actually performed better coming off bypass than their cohort. We did a warm-up study where we took first-year residents and second-year residents out of the OR for 5 minutes. Half the group just sat and did nothing. Half the group practiced on a virtual simulator for bronchoscopy. Then they went back and did a sleep bronchoscopes. And the group that did the 5 minutes of warm-up on the simulator had less pink out, white out, and were more goal-directed and quicker to intubate the patient with the bronchoscope than the other team. Now, mind you, this deteriorated. This didn't show any difference in the CA2s who already had their skill set, and probably this 5-minute warm-up didn't add much, but it was very helpful for those that were just learning how to use the technology, and this is kind of an interesting study. And in a systemic review, again, of outcomes, again, there's suggestion that in situ simulation does help. In this sort of landmark study, Andretti and basically increased simulation every 6 months versus PALS every 2 years, and showed an overall survival going from in the low 30s to the mid 55s on pediatric wards. One would attribute that you're just doing it more frequently, and if they would have just done PALS certification more frequently, this too could have been accomplished. But this has always quoted as a fairly large landmark study that demonstrated the use of simulation in true patient outcome improvement. When looking at team steps effectiveness, they actually took 3 hospitals. One hospital did nothing. One hospital had team steps didactics. Only one hospital did team steps and simulation, and this was a peripartum hospital. As it turned out, the team steps didactics and the control had no improvement, and so it needed simulation training to enrich the team steps enrichment, and there was an improvement in prenatal mortality morbidity by 37%, which is kind of remarkable, but it does need the training. Didactics alone, as we keep saying, doesn't really have much of an effect. What really has an effect, and this sort of goes back into your domain, is the use of part task training, and they could be high scale versus low scale or high tech versus low tech, and that's the use of simulation to teach central line placement to decrease bloodborne infection, which we saw we're not doing as well as we could from the leapfrog and our own data supplied to them. But the use of simulation as a component of one's training has been demonstrated to reduce infection rates in a variety of different articles. My own personal, this is a one-off, but this is my own personal, I think, triumph, was this is the Anesthesia Patient Safety Foundation. I got an email out of the blue thanking me for our MOCA course, the Maintenance of Certification for Anesthesiology. And it was from an anesthesiologist who says he was working in a surgery center in Connecticut. And lo and behold, he had just taken our course and there was a catastrophic event. It was a zebra. There was a line oxygenation failure. What happened? There was a pipeline leak, and they fixed it by flushing the leak with nitrogen, making sure it was, and they forgot to reflush the line with oxygen, so everyone was getting nitrogen and everyone had a desaturation. It was published in the Anesthesia Patient Safety Foundation about this experience, and we received this email basically telling us that the exact scenario that we ran in the simulator helped him not only save his patient's life, but alerted the media to everyone else in the center, and no one was hurt by these events. And I will tell you, this is the event that we studied about in terms of our residents being the most memorable, because no one picks it up as we swap. The pressures stay the same, but the FiO2 goes down because there's a contamination of the oxygen. And everyone thinks that's a zebra. It can't possibly happen. Well, it happened in a very affluent environment in Connecticut in a surgery center, not in a third world country where they're working off tanks. It's kind of remarkable. So where do we go with future directions as we wind this lecture up? Well, maybe there's going to be mandatory simulation training and assessment. We've moved into some screen-based because the logistics of everyone coming to a simulator center is really difficult. And how could virtual and augmented realities be helpful? And how do we improve our interprofessional training given what role and goal could that be, given that there's a high likelihood of our problems are communication? And how can we use these technologies to improve our integration improvement? And is there possibility of using simulation as a true rehearsal? And how about therapeutic simulation? And there are specialties that use simulation actually as a device to help patients. And are there ever going to be definitive outcome studies? So I just looked and sent to Mike Lightman and just checked it out to see how many RRCs actually require simulation. I actually thought emergency medicine did. It does not. And there are only a few specialties that actually require simulation as part of the training component. Anesthesiology is limited, but it is a required. You have to do one experience in CRM type skills. And there, again, it's listed here. It used to be to maintain your American Board of Anesthesiology that simulation-based training was a mandatory requirement as part of the MOCA, the Maintenance of Certification of Anesthesia. And the ASA put together this network of simulated educational centers. We are one of them that's endorsed by the ASA to conduct MOCA-based courses to maintain one's certification. Well, there was a backlash against MOCA or MOC universally, and there was a backlash, and they increased. Now there's 15 to 16 different events you can do to get credit for Part 4. So the immersive simulation activity is no longer required. It's but one activity. It's graded as a 3-to-1, 3 credit hours for 1 hour of simulation, etc. To enrich the access to simulation, I was the editor-in-chief of an editorial board, and I've stepped down and a member of the board now, of developing screen-based simulation activities, which is a lot harder than it looks. We developed a screen-based environment. It's immersive, it's autonomous, it's physiologically driven, and there are 2 in the works, 5 are out there, and they do satisfy MOCA requirements. I usually joke in the audience, if I was sitting in front, and say, guess what kind of surgeon this is? And I would say we hit it pretty right, and I don't have, the speakers can't be off, but if you guessed orthopedics, you'd be absolutely right, because I think we nailed the avatar. And this is our orthopedics, and we've immersed our anesthesiologist into the working environment. Everything is has an interface, including the anesthesia machines, the pumps, the infusions, etc. And we developed several different modules: trauma, appendectomy, robotics, in the PACU, and in labor and delivery. What about working in an environment has to do with, and the team-based issue? Well, this was a study that was done by the group that actually looked at incivility, and I know many of you have heard Sam talk about incivility. If someone presented themselves, if the surgeon had incivility to anyone in the environment, it shut down communication and made the anesthesiologist resident act poorly, not only in communication, but they flubbed all the other interactions. Which is really kind of shocking, but not really shocking, because if someone acts out, acts up, and think about your own environment, you're not likely to ask questions, you're not likely to communicate, you're not likely to tell them when there's problems, you're not likely to say you don't know something if the environment is hostile, and that really is, and we've all been there. And depending on which side of the screen you want to occupy, we've all had to deal with the difficulties of personalities. And interdisciplinary education really helps work through these issues, and it allows people to see how they behave and how that behavior can negatively influence others, and how good behavior can be modeled by our trainees. This article just came out that actually debunked it, and they said it didn't matter, so it's still up in the air. In Harvard, their CRICO is self-contained, just like our HIC. Many of you remember the HIC process we used to have required to maintain your privileges at Sinai, and you'd have to go through HIC training. We do mini MOCAs. Well, at Harvard, they reduced the premium for insurance. Interestingly, they put the teams together, and this is required. And interestingly, of communication, the blue is surgeons, the nurses are the orange, and the green is anesthesiologists. Communication was thought to be improved dramatically by surgeons. And surprisingly, I found that the assertiveness actually went up the most with anesthesiologists instead of the nurses, because if you look at the literature on incivility, most of that literature comes out of the nursing literature about MD incivility towards nursing, and the thought that this enriched the assertiveness anesthesiologists was kind of surprising to me. Or aspirationally, maybe if we put a headset on, now that, you know, the Apple eyewear, maybe that will fail. If we put a headset on, immerse you in the SimStat environment, and if you feel compelled to want to punch that guy, I think we've done a good job. But now we can actually have team-based learning without the team. And we actually used that as we developed an autonomous cardiovascular system using voice recognition, and actually showed it actually was as efficacious as learning ACLS protocols with an actual real team. And these were the virtual images that people were practicing, and there was eye motion activities and voice recognition. And we actually showed that VR could be used to train people up in an ACLS protocol. Gainesville actually flipped it on its side to improve the efficacy of team-based training, and actually created the team was the avatars. And instead of putting you in a virtual sort of screen-based, goggle-based environment, they actually created screen-based avatars to work as the team in the mixed simulation environment with the mannequins. What else could virtual reality be used for? Well, architects can actually use it to assess a new building, and that includes new hospitals, new environments, new wards, new ICUs, etc. And you can imagine the power of that. Wow, this looks great on paper, but maybe there's unintended consequences by this circular approach. Yeah, it's innovative. Yeah, it's novel. Yeah, it's neat. This looks great. Let's just build it. And then you have, you know, buyer's remorse. Well, imagine if you could put on a goggle and walk amongst the circular environment and recognize that maybe there's problems, maybe there's difficulties, maybe lines of sight might be problems, etc. And maybe you'd prefer just to go back to a traditional ICU. Wouldn't that be powerful to be able to do before you invest all that money into creating an environment? Well, lo and behold, Sinai didn't do that. They opened up a new NICU. And they opened it it went from being a PACU open space to a closed sort of cubicle space. And what ended up happening is they ended up having a MRSA outbreak that they couldn't cure. They called in the CDC, they did multiple washes, they did terminal washes, they did this, they did that. They worked for months. And then they called the simulator team in, myself, Andrew Goldberg, and Sam DiMaria, and through looking for latent safety threats and using simulation, what we recognized is there was no line of sight. And so when someone had problems, they actually had to come in and out and in and out in bi-directional motion within the cubicle to get help. And that created the cross-contaminations. And then the bassinets they were cleaning multiple times were just put in the pool. And we used simulation to curb it, cut it down, and shut it down immediately. And there was no recurrence of the MRSA using simulation. We also use simulation to identify problems within our team-based anesthesia model. We used to send solo residents to the airway management, and we recognized that people could have significant cardiovascular and dysrhythmic phenomenon they wouldn't know, especially since the monitors are in the back in the ICUs. And so we now recommend and use simulation to educate and inform us on how we should send at least 2 people to every airway when possible to better improve patient care, etc. And we use simulation that recognized it and that modeled how we would move forward into the clinical environment. Psychiatry uses simulation and virtual reality to take care of phobias, etc., and post-traumatic stress effectively. In our pain management, virtual reality and in the ORs for procedural, it can be used not only as a distraction, but it actually is thought to be therapeutic, and it changes the decorum of one's brain and brain chemistry, and it actually is therapeutic to use for that. True rehearsal. You can plug someone's anatomy into these simulators now and actually practice. Neurosurgery does it, orthopedics builds models and fractures them. OMSF does the full head, skull, and creates the fractures and the replaceable models, etc. And you can actually have full rehearsal. One could imagine you could plug the anatomy in and do the full surgery. You could plug it into a robot, train the robot, let AI perfect the skills, and then let the robot go and do the surgery itself. Ultimately, not only practice, but teach the robot how to practice. Without going over this litany, we've gone through an entire sort of tour de force of simulation and its utilization, some proven benefits, where it can be used. And I think we're still in the environment where aspirationally healthcare hasn't arrived at the place where it is adopted like other high reliability organizations, and we're still looking for the results. And although people believe it will ultimately be part of our culture, it isn't there yet. And to leave you on a note from Dave Gaba, one of the fathers of simulation, I think his quote, I'm not one to quote others other than myself, but his quote is quite memorable. No industry in which human lives depend on the skills, performance, responsible operators has waited for unequivocal proof of the benefits, and why should we in healthcare? So with that, thank you. I know I literally hit the moment of truce, not to keep you, and I hope you have kept awake, and I want to thank you. And I know it's getting late, but I am open to any questions. And then I am going to go back to my simulated vacation, since I am on vacation, and was pleased to come in and talk with you guys today about
Adam, that was
a
great.
passion.
Thank you so much for coming in on your vacation. I know that was great. I'd like to open it up to any questions from the group before we finish. Dr. Gidwani, do you have something?
I just want to thank Adam. You know, his uh, interns come to the cardiac ICU, and we do a little bit more than simulated work here. But thank you for, as you said, the tour de force of the review of simulation. And it's just so exciting, virtual reality and these new headsets. I suspect the prices are going to come down and the software is going to improve to a point where maybe you can overcome, or we can, see if it overcomes some of the limitations of plastic models and tactile sensations and things like that, because uh, that would get rid of so much of the non-virtual stuff, the real stuff, and get into, you can pretty much. So are you working with any of these companies, maybe Meta or Apple, to get into their simulation? Is anyone doing that from Sinai?
So we have embarked on working with a company in California. Dan Katz has been active in working with a company, and that's where we came up with the ACLS and the virtual. We have adopted a new. We've developed. Patrick Mafucci is one of our MD PhDs, but he was a head TA with Jeff Laitman in the anatomy lab, and he's been incorporating anatomy within our curriculum. And we just invested a large sum of money in virtual reality anatomy to carry it through from the cadavers. And there's a lot of, and we have to develop the curriculum. So we are, and that will then get rolled in not only in regional anesthesia, but cardiac anesthesia, cardiac function, and others. And want to just, we'll invite you to come down and see the technology, Umesh, because I believe, we always talk about the TE and the TT in form and function for anesthesiology and why anesthesiologists need to understand this, but it's obviously critical in critical care and the ICUs as well. So you have an open invitation to check out what's going on. But I think developing these things, and the team is developing the curriculum that will, I don't know if will get rolled into everywhere else, but it's going to be rolled into our program.
Thank you. It's past 2 o'clock and we have to go to another simulated meeting. Enjoy your vacation.
Well, thank you, Umesh. Always a pleasure. Umesh and I, we met during Ebola, and we've never looked back. And thank goodness we never had to.
And God forbid. Take care.